Brought to you by WikiVidi documentaries. Sepsis. Sepsis is a life-threatening condition that arises when the body's response to infection causes injury to its own tissues and organs. Common signs and symptoms include fever, increased heart rate, increased breathing rate, and confusion. There also may be symptoms related to a specific infection, such as a cough with pneumonia, or painful urination with a kidney infection. In the very young, old, and people with a weakened immune system, there may be no symptoms of a specific infection, and the body temperature may be low or normal, rather than high. Severe sepsis is sepsis causing poor organ function or insufficient blood flow. Insufficient blood flow may be evident by low blood pressure, high blood lactate, or low urine output. Septic shock is low blood pressure due to sepsis that does not improve after reasonable amounts of intravenous fluids are given. Sepsis is caused by an immune response triggered by an infection. Most commonly, the infection is bacterial, but it may also be from fungi, viruses, or parasites. Common locations for the primary infection include lungs, brain, urinary tract, skin, and abdominal organs. Risk factors include young or old age, a weakened immune system from conditions such as cancer or diabetes, major trauma, or burns. An older method of diagnosis was based on meeting at least two systemic inflammatory response syndrome criteria due to a presumed infection. In 2016, SIRS was replaced with QSOFA, which is two of the following three: increased breathing rate, change in level of consciousness, and low blood pressure. Blood cultures are recommended preferably before antibiotics are started. However, infection of the blood is not required for the diagnosis. Medical imaging should be used to look for the possible location of infection. Other potential causes of similar signs and symptoms include anaphylaxis, adrenal insufficiency, low blood volume, heart failure, and pulmonary embolism, among others. Sepsis usually is treated with intravenous fluids and antibiotics. Typically, antibiotics are given as soon as possible. Often, ongoing care is performed in an intensive care unit. If fluid replacement is not enough to maintain blood pressure, medications that raise blood pressure may be used. Mechanical ventilation and dialysis may be needed to support the function of the lungs and kidneys, respectively. To guide treatment, a central venous catheter and an arterial catheter may be placed for access to the bloodstream. Other measurements such as cardiac output and superior vena cava oxygen saturation may be used. People with sepsis need preventive measures for deep vein thrombosis, stress ulcers, and pressure ulcers. Unless other conditions prevent such interventions, some might benefit from tight control of blood sugar levels with insulin. The use of corticosteroids is controversial. Activated drotrocogon alpha, originally marketed for severe sepsis, has not been found to be helpful, and was withdrawn from sale in 2011. Disease severity partly determines the outcome. The risk of death from sepsis is as high as 30%, from severe sepsis as high as 50%, and from septic shock as high as 80%. The number of cases worldwide is unknown as there is little data from the developing world. Estimates suggest sepsis affects millions of people a year. In the developed world, approximately 0.2 to 3 people per 1,000 are affected by sepsis yearly, resulting in about 1 million cases per year in the United States. Rates of disease have been increasing. Sepsis is more common among males than females. The medical condition has been described since the time of Hippocrates. Septicemia and blood poisoning are terms that refer to the microorganisms or their toxins in the blood, and are no longer commonly used. Signs and symptoms. With sepsis from a meningococcal bloodstream infection, in addition to symptoms related to the provoking cause, sepsis frequently is associated with either fever, low body temperature, rapid breathing, elevated heart rate, confusion, and edema. Early signs are a rapid heart rate, decreased urination, and high blood sugar. Signs of established sepsis include confusion, metabolic acidosis, low blood pressure due to decreased systemic vascular resistance, higher cardiac output, and dysfunctions of blood coagulation. The drop in blood pressure seen in sepsis may lead to shock. This may result in lightheadedness. Bruising or intense bleeding may occur. Cause. The most common primary sources of infection resulting in sepsis are the lungs, the abdomen, and the urinary tract. Typically, 50% of all sepsis cases start as an infection in the lungs. No definitive source is found in 1/3 to 1/2 of cases. Infections leading to sepsis usually are bacterial, but may be fungal or viral. While gram-negative bacteria were previously the most common cause of sepsis, in the last decade gram-positive bacteria, most commonly Staphylococcus, are thought to cause more than 50% of cases of sepsis. Other commonly implicated bacteria include Streptococcus pyogenes, Escherichia coli, Pseudomonas aeruginosa, and Klebsiella species. Fungal sepsis accounts for approximately 5% of severe sepsis and septic shock cases. The most common cause of fungal sepsis is infection by Candida species of yeast, a nosocomial infection frequently acquired in hospitals. Diagnosis. Early diagnosis is necessary to properly manage sepsis, as initiation of rapid therapy is key to reducing mortality from severe sepsis. Within the first 3 hours of suspected sepsis, diagnostic studies should include white blood cell counts, measuring serum lactate, and obtaining appropriate cultures before starting antibiotics, so long as this does not delay their use by more than 45 minutes. To identify the causative organism, at least 2 sets of blood cultures using bottles with media for aerobic and anaerobic organisms should be obtained, with at least one drawn through the skin and one drawn through each vascular access device in place more than 48 hours. Even though bacteria are present in the blood in only about 30% of cases. Another possible method of detection is by polymerase chain reaction. If other sources of infection are suspected, cultures of these sources, such as urine, cerebrospinal fluid, wounds, or respiratory secretions, also should be obtained, as long as this does not delay the use of antibiotics. Within 6 hours, if blood pressure remains low despite initial fluid resuscitation of 30 ml per kilogram, or if initial lactate is 4 mmol per liter, central venous pressure and central venous oxygen saturation should be measured. Lactate should be remeasured if the initial lactate was elevated. Within 12 hours, it is essential to diagnose or exclude any source of infection that would require emergent source control, such as necrotizing soft tissue infection, infection causing inflammation of the abdominal cavity lining, infection of the bile duct, or intestinal infarction, a pierced internal organ, an abnormal chest X-ray consistent with pneumonia, or peachei, purpura, or purpura fulminans may be evident of infection. If the SIRS criteria are negative, it is very unlikely the person has sepsis. If they are positive, there is just a moderate probability that the person has sepsis. Definitions. There are different levels of sepsis: sepsis, severe sepsis, and septic shock. In 2016, a new consensus was proposed to replace screening by systemic inflammatory response syndrome with QSOFA. As of 2017, there remains some controversy around the change. SIRS is the presence of two or more of the following: abnormal body temperature, heart rate, respiratory rate, or blood gas, and white blood cell count. Sepsis is defined as SIRS in response to an infectious process. Severe sepsis is defined as sepsis with sepsis-induced organ dysfunction or tissue hypoperfusion. Septic shock is severe sepsis plus persistently low blood pressure, despite the administration of intravenous fluids. End organ dysfunction. Examples of end organ dysfunction include the following: lungs, acute respiratory distress syndrome, prolonged chronic lung disease. The ratio of the arterial partial pressure of oxygen to the fraction of oxygen in the gases inspired to greater than 65 to or over baseline PaCO2, or supplemental oxygen requirement of greater than FiO2 0.5. To maintain oxygen saturation 92%. Neurologic dysfunction, Glasgow Coma Score 11, or altered mental status with drop in GCS of 3 or more points in a patient with developmental delay, intellectual disability. Hematologic dysfunction, platelet count, or 50% drop from maximum in chronically thrombocytopenic patients, or international normalized ratio greater than 2. Disseminated intravascular coagulation, kidney dysfunction, serum creatinine 2 times the upper limit of normal for age, or twofold increase in baseline creatinine in patients with chronic kidney disease. Liver dysfunction, total serum bilirubin 4 mg per deciliter, or alanine aminotransferase 2 times the upper limit of normal. Consensus definitions, however, continue to evolve, with the latest expanding the list of signs and symptoms of sepsis to reflect clinical bedside experience. Biomarkers. A 2013 review concluded moderate quality evidence exists to support use of the procalcitonin level as a method to distinguish sepsis from non-infectious causes of SIRS. The same review found the sensitivity of the test to be 77%, and the specificity to be 79%. The authors suggested that procalcitonin may serve as a helpful diagnostic marker for sepsis, but cautioned that its level alone cannot definitively make the diagnosis. A 2012 systematic review found that soluble urokinase-type plasminogen activator receptor is a non-specific marker of inflammation and does not accurately diagnose sepsis. This same review concluded, however, that super has prognostic value, as higher super levels are associated with an increased rate of death in those with sepsis. Differential diagnosis. The differential diagnosis for sepsis is broad and has to examine the non-infectious conditions that may cause the systemic signs of SIRS: alcohol withdrawal, acute pancreatitis, burns, pulmonary embolism, thyrotoxicosis, anaphylaxis, adrenal insufficiency, and neurogenic shock. Also, hyperinflammatory syndromes like hemophagocytic lymphohistiocytosis have similar symptoms and should be included in differential diagnosis. Neonatal sepsis. In common clinical usage, neonatal sepsis refers to a bacterial bloodstream infection in the first month of life, such as meningitis, pneumonia, pyelonephritis, or gastroenteritis, but neonatal sepsis also may be due to infection with fungi, viruses, or parasites. Criteria with regard to hemodynamic compromise or respiratory failure are not useful, because they present too late for intervention. Pathophysiology. Sepsis is caused by a combination of factors related to the particular invading pathogen and to the status of the immune system of the host. The early phase of sepsis, characterized by excessive inflammation, may be followed by a prolonged period of decreased functioning of the immune system. Either of these phases may prove fatal. Microbial factors. Bacterial virulence factors, such as glycocalyx and various adhesions, allow colonization, immune evasion, and establishment of disease in the host. Sepsis caused by gram-negative bacteria is thought to be largely due to a response by the host to the lipid A component of lipopolysaccharide, also called endotoxin. Sepsis caused by gram-positive bacteria may result from an immunological response to cell wall lipoteichoic acid. Bacterial exotoxins that act as superantigens also may cause sepsis. Superantigens simultaneously bind major histocompatibility complex and T-cell receptors in the absence of antigen presentation. This forced receptor interaction induces the production of pro-inflammatory chemical signals by T-cells. There are a number of microbial factors that may cause the typical septic inflammatory cascade. An invading pathogen is recognized by its pathogen-associated molecular patterns. Examples of PAMPs include lipopolysaccharide and flagellin in gram-negative bacteria, muramyl dipeptide in the peptidoglycan of the gram-positive bacterial cell wall, and CpG bacterial DNA. These PAMPs are recognized by the pattern recognition receptors of the innate immune system, which may be membrane-bound or cytosolic. There are 4 families of PRRs: the toll-like receptors, the C-type lectin receptors, the nod-like receptors, and the Rig-I-like receptors. Invariably, the association of a PAMP and a PRR will cause a series of intracellular signaling cascades. Consequentially, transcription factors such as nuclear factor kappa B and activator protein 1 will upregulate the expression of pro-inflammatory and anti-inflammatory cytokines. Host factors. Cytokines such as tumor necrosis factor, interleukin-1, and interleukin-6 may activate procoagulation factors in the cells lining blood vessels, leading to endothelial damage. The damaged endothelial surface inhibits anticoagulant properties as well as increases antifibrinolysis, which may lead to intravascular clotting, the formation of blood clots in small blood vessels, and multiple organ failure. A systemic inflammatory response syndrome also may occur in patients without the presence of infection, for example, in those with burns, polytrauma, or the initial state in pancreatitis. In chemical pneumonitis, the low blood pressure seen in those with sepsis is the result of various processes, including excessive production of chemicals that dilate blood vessels such as nitric oxide, a deficiency of chemicals that constrict blood vessels such as vasopressin, and activation of ATP-sensitive potassium channels in those with severe sepsis and septic shock. This sequence of events leads to a type of circulatory shock known as distributive shock. Management. Early recognition and focused management may improve the outcomes in sepsis. Current professional recommendations include a number of actions to be followed as soon as possible after diagnosis. Within the first 3 hours, someone with sepsis should have received antibiotics and intravenous fluids if there is evidence of either low blood pressure or other evidence for inadequate blood supply to organs. Blood cultures also should be obtained within this time period. After 6 hours the blood pressure should be adequate. Close monitoring of blood pressure and blood supply to organs should be in place, and the lactate should be measured again if initially it was raised. A related bundle. The Sepsis 6 is in widespread use in the United Kingdom. This requires the administration of antibiotics within an hour of recognition, blood cultures, lactate and hemoglobin determination, urine output monitoring, high-flow oxygen, and intravenous fluids. Apart from the timely administration of fluids and antibiotics, the management of sepsis also involves surgical drainage of infected fluid collections and appropriate support for organ dysfunction. This may include hemodialysis in kidney failure, mechanical ventilation in lung dysfunction, transfusion of blood products, and drug and fluids therapy for circulatory failure. Ensuring adequate nutrition, preferably by enteral feeding, but if necessary, by parenteral nutrition, is important. During prolonged illness, in those with high blood sugar levels, insulin to bring it down to 7.8 to 10 mmol per liter is recommended, with lower levels potentially worsening outcomes. Medication to prevent deep vein thrombosis and gastric ulcers also may be used. Antibiotics. In severe sepsis and septic shock, broad-spectrum antibiotics are recommended. Some recommend they be given within 1 hour of making the diagnosis, stating that for every hour of delay in the administration of antibiotics, there is an associated 6% rise in mortality. Others did not find a benefit with early administration. 2 sets of blood cultures should be obtained before starting antibiotics if this can be done without delaying the administration of antibiotics. Several factors determine the most appropriate choice for the initial antibiotic regimen. These factors include local patterns of bacterial sensitivity to antibiotics, whether the infection is thought to be a hospital or community-acquired infection, and which organ systems are thought to be infected. Antibiotic regimens should be reassessed daily and narrowed if appropriate. Treatment duration is typically 7 to 10 days, with the type of antibiotic used directed by the results of cultures. Giving antibiotics continuously may be better than giving them intermittently. Intravenous fluids. Intravenous fluids are titrated in response to heart rate, blood pressure, and urine output. Restoring large fluid deficits can require 6 to 10 liters of crystalloids in adults. In children, an initial amount of 20 milliliters per kilogram is reasonable in shock. In cases of severe sepsis and septic shock where a central venous catheter is used to measure blood pressures dynamically, fluids should be administered until the central venous pressure reaches 8 to 12 millimeters of mercury. Once these goals are met, the central venous oxygen saturation, i.e., the oxygen saturation of venous blood as it returns to the heart as measured at the vena cava, is optimized. If the ScVO2 is less than 70%, blood may be given to reach a hemoglobin of 10 grams per deciliter, and then inotropes are added until the ScVO2 is optimized. In those with acute respiratory distress syndrome and sufficient tissue blood fluid, more fluids should be given carefully. Crystalloid solutions are recommended initially. Crystalloid solutions and albumin are better than other fluids in terms of risk of death. Starches also carry an increased risk of acute kidney injury and need for blood transfusion. Various colloid solutions carry no advantage over crystalloid. Albumin also appears to be of no benefit over crystalloids. Packed red blood cells are recommended. to keep the hemoglobin levels between 70 and 90 grams per liter. A 2014 trial, however, found no difference between a target hemoglobin of 70 and 90 grams per liter. Vasopresses. If the person has been sufficiently fluid resuscitated, but the mean arterial pressure is not greater than 65 mm of mercury, vasopresses are recommended. Norepinephrine is recommended as the initial choice. If a single vasopressor is not enough to raise the blood pressure, epinephrine, a vasopressin, may be added. Dopamine is typically not recommended. Dobutamine may be used if heart function is poor, or blood flow is insufficient despite sufficient fluid volumes and blood pressure. Ventilation. Etomidate is often not recommended as a medication to help with intubation in this situation due to concerns it may lead to poor adrenal function and an increased risk of death. The small amount of evidence there is, however, has not found a change in the risk of death with etomidate. It is recommended that the head of the bed be raised if possible to improve ventilation. Paralytic agents should be avoided unless ARDS is suspected. Steroids. The use of steroids in sepsis is controversial. Studies do not give a clear picture as to whether and when glucocorticoids should be used. The 2012 Surviving Sepsis campaign recommends against their use in those with septic shock if intravenous fluids and vasopresses stabilize the person's cardiovascular function. While a 2015 Cochrane review found low-quality evidence of benefit during critical illness, a state of adrenal insufficiency and tissue resistance to corticosteroids may occur. This has been termed critical illness-related corticosteroid insufficiency. Treatment with corticosteroids might be most beneficial in those with septic shock and early severe ARDS, whereas its role in others such as those with pancreatitis or severe pneumonia is unclear. However, the exact way of determining corticosteroid insufficiency remains problematic. It should be suspected in those poorly responding to resuscitation with fluids and vasopresses. ACTH stimulation testing is not recommended to confirm the diagnosis. The method of stopping glucocorticoid drugs is variable, and it is unclear whether they should be slowly decreased or simply abruptly stopped. Early goal-directed therapy. Early goal-directed therapy is an approach to the management of severe sepsis. During the initial 6 hours after diagnosis, it is a stepwise approach, with the physiologic goal of optimizing cardiac preload, afterload, and contractility. It includes giving early antibiotics. It involves monitoring of hemodynamic parameters and specific interventions to achieve key resuscitation targets, which include maintaining a central venous pressure between 8 to 12 mm of mercury, a mean arterial pressure of between 65 to 90 mm of mercury, a central venous oxygen saturation greater than 70%, and a urine output of greater than 0.5 ml per kilogram per hour. The goal is to optimize oxygen delivery to tissues and achieve a balance between systemic oxygen delivery and demand. An appropriate decrease in serum lactate may be equivalent to SCVO2 and easier to obtain. In the original trial, early goal-directed therapy was found to reduce mortality from 46.5% to 30.5% in those with sepsis, and the Surviving Sepsis campaign has been recommending its use. However, 3 more recent large randomized control trials did not demonstrate a 90-day mortality benefit of early goal-directed therapy versus the standard Therapy in severe sepsis. It is likely that some parts of EGDT are more important than others. Following these trials, the use of EGDT is still considered reasonable. Newborns. Neonatal sepsis can be difficult to diagnose as newborns may be asymptomatic. If a newborn shows signs and symptoms suggestive of sepsis, antibiotics are immediately started and are either changed to target a specific organism identified by diagnostic testing, or discontinued after an infectious cause for the symptoms has been ruled out. Other. Treating fever in people with sepsis does not affect outcomes. Monoclonal and polyclonal preparations of intravenous immunoglobulin do not lower the rate of death in newborns and adults with sepsis. Evidence for the use of IgM-enriched polyclonal preparations of IVIG is inconsistent. A 2012 Cochrane review concluded that N-acetylcysteine does not reduce mortality in those with SIRS or sepsis and may even be harmful. Recombinant activated protein C was originally introduced for severe sepsis, where it was thought to confer a survival benefit. However, subsequent studies showed that it increased adverse events, bleeding risk in particular, and did not decrease mortality. It was removed from sale in 2011. Another medication known as Eritrea also has not shown benefit. Prognosis. Approximately 20 to 35% of people with severe sepsis and 30 to 70% of people with septic shock die. Lactate is a useful method of determining prognosis, with those who have a level greater than 4 mmol per liter having a mortality of 40% and those with a level of less than 2 mmol per liter have a mortality of less than 15%. There are a number of prognostic stratification systems such as Apache 2 and mortality in emergency department sepsis. Apache 2 factors in the person's age, underlying condition, and various physiologic variables to yield estimates of the risk of dying of severe sepsis of the individual covariates. The severity of underlying disease most strongly influences the risk of death. Septic shock is also a strong predictor of short and long-term mortality. Case fatality rates are similar for culture-positive and culture-negative severe sepsis. The mortality in emergency department sepsis score is simpler and useful in the emergency department environment. Some people may experience severe long-term cognitive decline following an episode of severe sepsis, but the absence of baseline neuropsychological data in most sepsis patients makes the incidence of this difficult to quantify at a study. Thank you for watching. Brought to you by WikiVidi Documentaries. Please like and subscribe below. Please like and subscribe below.